Welcome to the first conference on integrating early detection of heart and lung diseases and the 46th International Conference on Screening for Lung Cancer. We've been doing this for a long time, and the 14th Conference on the Initiative for Early Lung Cancer Research on Treatment. So, as I said, we started in 1992 to talk about screening. It took us until 1998 to really recruit 1,000 people, which we did, and that resulted in the Lancet publication in 1999. And then all people were becoming interested. I want to remind you that it all started at Weill Cornell with Dean Gatto at the head, and the senior. When I initially tried to get through the IRB, it never went through the IRB, but Jim Smith, the senior pulmonologist, went with me to the IRB, and we got it through in 10 minutes after that. Mark Pasmentier was a senior oncologist, and Dr. Nasser Al-Turki was a thoracic surgeon, and David Skinner was the president. And that was the initial team. It took all of that team to make it work. So we then expanded to the international I-ELCAP, and I'm proud to say we've now screened 102,000 participants in I-ELCAP in more than 80 institutions around the world, and we're still growing. So thank everybody for all of that. It's throughout the world, and we're expanding into new continents of Africa and South America, which I'll talk about at the other talks. So we were finally, through that collaboration, we were able to give the 20-year lung cancer specific survival, which was really very terrific. It was 80% for all comers, whether diagnosed through the screening or in between screening rounds, baseline or annual. And if you found it in the earliest stage, pathologic stage, the survival was 95%. So really that's outstanding. So we can really cure lung cancer if we keep working towards that and finding it earlier and earlier. And that's one of the purposes of this meeting. We want to thank Dr. Luis Sejo from the Universidad de Navarra. They were one of our first institutions that joined us. And he hosted our last conference in Madrid. And we thank Mateusz Utkirk for suggesting the Agile collaboration and the Agile planning team of Jim Mulshine, John Field, Mario Silver, and Luis Sejo. So these collaborations are very important, and we appreciate all the hard work towards that. We had worldwide registration, over 400. We hope to have even more at this meeting and in future meetings. So the goals of our 46th conference is to maximize the benefit of screening. And we need to keep rethinking and optimizing all components of both the diagnostic and the treatment paradigm to reach that 95% or maybe even higher. We've done that by looking at all the organs that we see on the chest CT. This time we're focusing on the heart, on the lungs, and on the liver, but you really need to report on all of those organs. For these screening reports, we provide the information on the report of the nodule location, the size, and the change. We provide the information on each of the visualized organs in the chest. And we collaborate with relevant medical specialties and engineering experts to really provide the correct information, because in a screening setting is very different than in the usual clinical setting. In screening, you're looking at a whole population. You want to be very careful what your recommendations are in order not to do harms. And we've published in peer-reviewed journals, and I'll just review that a little bit on each topic prior to making recommendations. So for coronary artery calcifications, we looked at that from early on because we said we see those, and Dr. Shemish, who's here, where are you, Dr. Shemish? There you are, worked with us early on in doing that. We developed the ordinal scoring, CAC scoring. So we said for each 4 arteries, we classify the calcifications as to none, mild, moderate, or severe. That gives us a possible score from 0 to 12. And then we showed that, that having a score of 4 or more gave you an odds ratio of a hazard ratio of 2.1 compared to a score of lower. So we make recommendations for each of those. And radiology in 2010, when we published the second article on that, said they had an editorial where they quoted the 3 papers that I listed here, Shemish, Gondry, and Budoff, that said, these are things that we can see on the CT, we can quantify them, and the editorial said to radiologists, it's important to provide quantitative information, post-processing information. So I want to really underscore that because we've been moving towards that and we need to do even more. We looked at the agreement between the ordinal and the Agatston scores, and we also looked at never smokers because we had a grant from the Flight Attendants Medical Research Institute. Those are all those flight attendants who had that passive smoking exposure. And in the second talk later today, I'll talk about the score that we developed for the passive smoking exposure. But we showed that if you have low, moderate, or high exposure, you have an increasing risk of coronary calcifications. So that was a very important paper that was published. We also looked at quantifying the extent of emphysema, as you see here, and we said you can have mild, moderate, or severe, and we developed the hazard ratios for lung cancer or for COPD survival. If it's moderate emphysema, there was a hazard ratio of 17.3, and for marked, it was 43. So there's a marked prediction value of emphysema and the quantification of emphysema. We looked at emphysema phenotypes that depending on the type of severity and where it's located, that also provides additional information. And we showed that when never smokers have emphysema, they're at the same risk of lung cancers as smokers. And that's something that's really not understood. So quantifying the extent of the passive smoking exposure and knowing what the CT shows is very important. We looked at aortic calcifications, and we score each of those as none, mild, moderate, or severe in each of our reports. The yellow that you see there is coronary calcium, aortic valve calcifications, as compared to the pink, which is mitral valve. So you need to carefully distinguish them, and these are all things that are needed in the training of radiologists reading these scans or in the AI algorithms that are being developed. We looked at we talk about the entire aorta, whether it's how much calcification there is. And then we look at the lungs. We carefully evaluated bronchiectasis because we said if you can find that early, maybe we can intervene and keep it from becoming worse. And that's ongoing research that you'll hear about today as well. We publish lots of things about the liver because in the World Trade Center, which we have the data and we have experts, Andrea Branch, and you'll hear a talk by Dr. Fried later. This is really an important finding, and the correlation of the liver with heart, with lung, all of those things are unexplored. So that's one of our many goals. We reported on interstitial lung disease and breast parenchymal disease that you can see on low-dose CT. In fact, if you see the density readings, the agreement among mammographers is much better if you look at CT scans than the mammogram. So we published on that. And when you see artery calcifications on a mammogram, we said that's predictive of coronary artery disease as well. And then they said, oh, well, but women don't want to know that from their mammogram. They're focused on the breast. And we had a survey, Lori Margulis did a survey and said, of course women want to have that information. So that's the answer to all that information that we want to get from the CT scan. We looked at osteoporosis. And back in 2017, together with Tony Reeves, who's sitting somewhere also in the audience, we said, well, we should have a digital report. And at that time, we had it for nodule detection, for growth, for emphysema, coronary artery calcifications, but we needed to further develop that. And later on, we developed a more extensive quantitative report. And so the exciting thing about this meeting is that we're going to expand that. We're going to talk about chamber size, and Mort will talk about that. He's done terrific work. And really, we need to quantitate the osteoporosis and the liver, and that's the focus of this conference. And really, that's bringing in a new era of preventive health. Really, we need to start thinking about it differently. We need to think about health rather than illness. So those are all exciting things for the future. So the sun is rising on early diagnosis and early treatment. And we thank all of our I-ELCAP investigators and their teams throughout the world, really from 1999 till today. That's a long time, and each and every one of those investigators are important for us. And special thanks to the thousands of screening participants that we have that have generously given us their data and allowed us to report on that. So for the future, we have the next joint meeting with Agile, which is the European component, from April 3rd to April 5th next year in Bangkok. We're at one of our previous fellows is helping coordinate that. She's a pulmonologist at the Princess, I can't really pronounce that name, but the College of Medicine in Bangkok. And then the next date, the follow-up of this conference is going to be September 18th to the 20th in New York City. So we look forward to all sorts of new developments by then. Thank you very much.
Good morning and welcome. This is truly a trailblazer type event, crossing the lung cancer screening world and cardiovascular prevention and early detection world. I come from the cardiology side. I started SHAPE, Society for Heart Attack Prevention and Eradication, which started from vulnerableplaque.org. And our notion was to go out and detect people before they become an acute coronary disease and symptomatic. When I met Claudia and David about 5 years ago, we thought that we were united with a chest CT scan. A chest CT scan has information both for cardiology side and for lung cancer screening. So we quickly evolved our thoughts, and what you'll see, a quick overview of what we've accomplished in the past 2-3 years. We went through a pandemic together. So why are we here? The main element of our work is we are able non-invasively to detect the early stage of CVD and lung cancer using a low-dose CT scan. It is not a research tool anymore. It's a clinical tool, widely available. It's available all the way in India and China and developing countries. And it's ready for mass adoption. And, sorry, AI has made it possible to deliver it on a cost-efficient, human resource-wise efficient, and inexpensive manner. So those are the key momentum makers that brought us here. But why do we have to do this? This is the grimmest statistics that have been here for over 20 years, at least during my decades in cardiology. And that is, for coronary disease, for cardiovascular disease, we really don't have any early stage screening platform. We do screening for blood pressure, we do screening for hyperlipidemia and diabetes, but we don't have a screening for early detection of pre-symptomatic disease. And we just wait till somebody comes in with chest pain and we throw everything we have at them. So these two statistics need to change in order for us to make a difference in primary prevention of the number 1 and number 2 killers. I want to shoot something here. I'm sure Dr. Harrington has much more detailed slide to share with you about the burden of cardiovascular disease. But when we go to cardiology meetings over the last 20, 30 years, we're all used to seeing this graph. This is a misleading graph. This does not represent the burden of the disease. This is called age adjusted. Now, and I was in a school of public health for a MPH program, so I relate to that. But this is not reality. Because when you say age adjusted, that means you treat people or our society as if we stuck in the same age distribution of 1900. But we are getting older. The population is aging. And the real statistics is this slide. This is not age adjusted. This is the reality. And you can see the age adjusted are the red and blue, but the reality of burden of disease keeps going up. And so that's the problem we're facing, and we need to make a difference. And that's worldwide. Worse in countries like China, Russia, and developing countries, as well as in the US. So this is what we've been working on over the past 3-4 years, particularly past 2 years, and we have some good success to share with you. Again, applying AI and new innovative technologies to the CT scans. The same work that Claudia and David started years ago, but combining it with cardiovascular is our focus. And if we do it well, we can handle in and out time within 7 minutes. And that's, you'll see in the subsequent slides that we're proposing to ARPA to fund this initiative for nationwide implementation. So the idea is we would make it widely available, particularly in mobile settings. People go in and out there going for their grocery shopping. They can scan a QR code on the back of this truck. They get the app. They answer a few questions. They, totally, we have over 35 million people that qualify according to our existing guidelines for coronary artery calcium score in the intermediate group and for lung cancer screening. And the AI does the initial reading, and then radiology or cardiology or any expert approves the report, and it brings it to a nurse practitioner or a patient advocate, somebody who can walk the patient through the findings. So I don't want to go into details of these, as Claudia mentioned. These are work that they have done. We're just applying it to an AI-based reader and make it easily available through app and cloud. So here's the thing. According to AHA-ACC guideline and the intermediate risk category group, we have about a little bit more than 35 now. 35 million people will qualify, would benefit from getting their calcium score. The total number today is less than 500,000. We don't have even accurate statistics because it's not covered by Medicare. So we don't have. So this is the proposal. On the right side, the lung scan will cover the entire lung, but for cardiovascular or calcium score imaging, we only cover the heart. So we don't have guidelines to go above the cardiac for this 33 or 35 million. That's one of the questions that we hope to discuss and bring to resolution or bring to an action plan for a writing group through this meeting. And so that was the highlight. So about 25 million, you take out the lung population, especially with the expanded definition of lung cancer screening. We need to answer that question, whether that extra dose for the upper part, 1/3 of the lung, is justifiable. And I quote David Yankelevitz, who's the expert, is telling me it's not going to be more than one chest X-ray for this amount of extra dose. And hopefully we can convince our colleagues to stop doing things like this, where they just leave out part of the lung and not cover, vertebra properly, and not cover the areas that the patient can get benefit from through the AI and getting actionable information. So first, we focus on what the U.S. Preventive Task Force Services has actual mandate osteoporosis screening. The information is there, no more radiation, no more extra time. So that's already FDA approved and is being propagated through systems to make it available. Mount Sinai just got it installed. This is the newest evolution of what we're doing, and that is using the non-contrast chest CT scan, cardiac scan, calcium score, and lung cancer screening. We'd be able to use AI to measure the volume of cardiac chambers and LV wall mass. And we have, over the past 2 years, shown that the data in the gated and non-gated lung scan are very similar. We published that the actual volume of LA, left atrium, can predict who will have atrial fibrillation, who will have atrial fibrillation, not having atrial fibrillation within a year. And we showed that compared to a standard of care, like Charge AF, which is a risk calculator, the LA volume does a much better job in identifying who is going to have atrial fibrillation. And then thanks to MESA, a longitudinal study of 20 years where people went through calcium score and MRI, you can see the AI measures LV volume and LV mass very similarly to MRI. And the AUC is total overlap, no difference. The same thing for predicting stroke, the AI and MRI. Of course, MRI is 30 minutes or so time, whereas this is a matter of a few seconds applying to existing scan, and you get opportunistically valuable information for predicting who will have a stroke and atrial fibrillation. So overall, we've shown that compared to the traditional Agatston score, this AI-enabled and improved version increases the area under the curve significantly for all categories. So that's what we're focusing on now and talking with FDA, whether we can allow a bundle reporting like this. Again, everything that Claudia and team over the past 25, 30 years pioneered in the lung cancer population, we bring it to the larger population that would qualify for cardiovascular screening and get a report like this that covers chambers, calcium, aorta, and so on. So this is the final slides. We're hoping that we can convince the new agency, ARPA-H, just like DARPA. This is ARPA for Advanced Research Program Agency for Health. They have mandates to make significant difference in healthcare. They have intention to create what they call moonshots. So our proposal to them is to allow us in a foreseeable 5 to 10 years, have 1,000 of these mobile units across the country in parking lots of retail or organizations like Walmart and Targets and Kroger's. It would be able to connect them through cloud and AI, have people, we go where people are, not waiting for them to come to hospitals and do the initial screening. And with that, the approach is we'll be able to prevent preventable death. Again, we may delay certain things, but we definitely can prevent the low-hanging fruit, those people with very significant subclinical disease that have no idea and walk around. So in summary, that is the proposal we're building on the back of this conference. We hope to build the brainstorming that we come from this meeting to what we call here reshaped, redefining screening for heart and pulmonary artery disease. These are my colleagues who have intellectually contributed to our work, and we look forward to publishing this after this meeting. Thank you very much for coming early and participating in this event.
I'm going to present some of the details of this conference now, and then we'll get started. So I really believe that we are at the inflection point. Lung cancer screening has had a slow rise, but the idea that we're finally able to really start integrating now with cardiology in a really meaningful way, I think is going to be like rocket fuel for this. And I really think that this is going to just enhance what's going on. I think there's a new era of preventive health that's about to happen. And I'm pleased to say that I think this conference, our dream is that this conference will really help make that happen. I want to say also that Claudia just received recently, a couple of weeks ago, she was given the Joseph Cullen Prevention Award for Early Detection at the IASLC, the International Association for the Study of Lung Cancer. And, you know, there was a time, believe it or not, where lung cancer screening was controversial. It seems like it never was a problem, but we're delighted that it's really moving into mainstream. We have a lot of people here to thank for that, from the American College of Radiology, from American Cancer Society, all of these organizations, American Lung Association, who are here today. All of them have really helped in making lung cancer screening become a reality, and it's gradually improving. Uptake is increasing. And I think this award that Claudia got is in large part recognition of that. Claudia mentioned this article, and I just wanted to, this was an editorial that came out in 2010, and it was based on these articles. And actually, the first was the osteoporosis, and that's integrated here. Matt Budoff's approach is being integrated into what Mort is doing. Shemesh has worked with us with Claudia, and we've integrated the ordinal scoring. And the third was on thoracic diseases and thoracic calcification. But the main point I wanted to bring out about this article was this is what they said, and this was really new at that time. In this issue of radiology, the idea of reporting all clinically relevant findings is taken to a new, exciting, and potentially more ambiguous level. In 3 separate studies, we discover that radiologists may be able to offer even more clinically relevant information that is based not on what we see, not on what we can see, but rather on what we cannot see, at least at first glance. These reports suggest a change in the paradigm from merely reporting the image findings to taking an extra analytical post-processing step to create and report a numeric finding that may help to assess a patient's risk for cardiovascular disease or osteoporosis. The idea of doing this was new at that time. And this is before the era of AI. I mean, it's really quite remarkable. And then they noted that if these reported methods hold true, it's uncertain when and for whom such post-processing analyses should be performed and reported. An even bigger problem today. This is going to be one of the topics we discuss. There's lots of things that you can find on these CTs and predict how we report it. Is it ethical to report? All of these are now becoming challenges. And finally, they concluded with this paradigm shift allows for a rich avenue for further research and development. Rather than shying away from this new responsibility, the radiology leadership should embrace the possibility of adding a new dimension to our profession. This is going to explode with AI. We have to figure out how to integrate this, but we feel that what we're doing now with low-dose CT of the chest, as Cheryl Healton described at our last meeting, is a new era in preventive health. And I believe that. Our conference, day 1 is really an introduction of the cardiology world. And I'm happy to say we have the Stanford gang here is going to help educate us. But we have a wonderful panel. They're going to really bring out all of the issues in cardiology that we feel will be addressed in these scans and how it's going to be integrated. And then we bring in the lung side of this, all of the illnesses in lung that we're able to identify and discussions on early diagnosis leading to early treatment. So it's a bit of an introduction of the two worlds. And then finally, there's a third section here on other findings, especially and they relate, liver disease, fat distributions, all of this interplays with all of these illnesses. Day 2 is how we work together, basically, how we build a common protocol, make it really efficient, how we optimize performing these together. And then there'll be issues related to some of the ethical considerations and also how organizations, advocacy organizations work together. You know, they've been siloed. There's cancer advocacy, there's cardiac advocacy. How do they work together? We've got to think of this in a much broader way. And on day 3, day 3 is primarily on lung cancer treatment, and that's our I-ELCAP program. And we'll be talking about opportunities for treatment and improving treatment of lung cancer. And we'll also give some technology updates. And Dr. Fuster is going to close off the meeting with a 45-minute lecture on cardiology, which we're delighted about. So that's the program. We have lunch here every day. Everybody's free for dinner tonight. When people come to New York City, they have their favorite restaurants. People in this room will meet each other and choose where they want to go. Friday night, we do have a special event, which I will get to in a moment. I want to first acknowledge the conference sponsors, the City of New York Research Foundation, GE Healthcare, Bristol Myers Squibb and Bristol Myers Squibb Foundation, Siemens, AstraZeneca, Araneta, United Imaging, Lilly, Celio, Acumetra, and Claudia's Research Foundation. And finally, we have supporters, the International Association for the Study of Lung Cancer, Prevent Cancer Foundation, American Lung Association, and the GO2 Foundation, as well as SHAPE and I-ELCAP are all supporters of this meeting. So we really appreciate all of this sponsorship and support. Two other additional announcements. We are delighted that we have Bruce Ratner here, who recently published this book, Early Detection, Catching Cancers When It's Curable. This is a wonderful book. This goes into the ideas of screening, and Bruce was motivated through family history to write this book. It's a wonderful read, and we are delighted that we have copies of the book here available to the audience members. I urge you to take it and read this book carefully. It really brings out the history of screening, why it's so important, and where this needs to go. And we also have this book, which is written by Mike McConnell, Fight Heart Disease Like Cancer. This is one of the best covers I've ever seen, I have to tell you. And Mike, too, was motivated by family history of illness and how it should be, how we should think about fighting heart disease. And he's using the cancer paradigm to help with that. And I think this is also a wonderful book. And we have copies of this book here as well. So I really urge people to take these books and read them. And the authors are both here. I hope you get a chance to speak with them. As I said, I think it's just wonderful. This is the direction we need to head in preventive health. I mentioned that there will be a reception tomorrow night at Claudia's house. This really isn't Claudia's house, by the way. In case you were confused, you might think it is, but this is a couple of blocks away from Claudia's house. But we have live entertainment. Isabel Stein, if some of you may remember, she performed at one of our meetings about a year ago. She's a wonderful jazz singer, and it'll be a lot of fun. This is on Friday night, and it's light food being served, and you can go out to dinner afterwards. And finally, I'm just going to end with this slide. These are the terms we use for all of these findings. When we read a CT scan, we talk about coronary calcium as an ancillary finding, or emphysema, or all this ancillary, opportunistic, incidental, newer term, bonus, opportunity, and just look at their definitions: ancillary, subordinate, or subsidiary. You know, I don't think of the coronary calcium findings as subordinate or subsidiary, opportunistic, exploiting opportunities with little regard for principle, incidental, being likely to ensue as a chance or minor consequence, etc. So I think we have to get rid of this terminology. I really don't like it. And I was talking to my colleague, Dr. Mulshine, the former provost at Rush University, he said that we really have to start thinking more, what was the word we used, Jim? Yeah, that we have to talk not about lung cancer screening. It's really an opportunity for preventive health. And all of these findings, none is subordinate to the other, none is incidental to the other. And so we've just got to make it that this is a much more holistic approach. And I think we'll come up with some new terminology for how we describe the scan, not calling it a lung screening scan. It's an opportunity for preventive health on these major comorbidities or morbidities that are all seen at the same time. And I think we've got to move in that direction. And with that, we're going to have our first speaker, and Dr. Marin, you're going to introduce him. Thank you.